Operating wide cataracts like these, which are apparently intumescent, is a problem during the rhexis. And so we have a patient here, and this is the B scan, and this is where the surgery starts. And as expecting that this cataract is going to be intumescent, and these cataracts are just like an inflated balloon. So just a small prick, and the rip which occurs is much more larger than the size you intend to make. So these capsules are very tight, and turgid lens matter causes very easy rupture of these capsules. So there are various techniques described to handle this rip or the Argentina flag sign, and here we will see one of them. The capsule has been stained, viscoelastic has been injected in the anterior chamber to flatten out the anterior capsule, and then a rhexis is attempted, which is relatively smaller in size than what is the final intention. The rhexis has to be made in a fashion so that it doesn't move out to the periphery, and you have a round opening which is not as big as intended to be. And this, at the same time, this will allow us to do the surgery because there's hardly any hard nucleus, and surgery can be completed through this rhexis. So as we can see, it's an intumescent cataract in a young patient, so there's not much a bulk of a nucleus which can be easily emulsified and aspirated out, as we will see that. However, the small rhexis has its own issues. You cannot reach up to the periphery, and so we have made a trench which weakens the nuclear material, and then we can simply go ahead, and the nucleus which has been apparently cracked can be simply emulsified by pulling it to center and using phaco power. So here we can see single-handedly this has been managed. Now about the remaining cortex, that becomes little tricky because the small rhexis traps this cortex, and one has to really undergo underneath the capsule and then engage the cortical matter, taking care that the capsule is not engaged because it is actually overlying these fibers. So one has to be careful regarding this, otherwise one can actually pull the capsule and cause zonal adhesions. Removing the subincisional cortex is equally tricky, and as I have mentioned earlier, the trick lies not in withdrawing your tool but rather going deep into the anterior chamber so that your infusion remains on. Some amount of subincisional cortex can always be left behind if it is not draping the posterior capsule, and then it can be safely removed once the IOL has been implanted, which will provide a nice shield over this posterior capsule so that there is no damage occurs when you are trying to remove the subincisional cortex. So here we have now the IOL in place, and the cortical matter is draped over the IOL, and this can be aspirated with the shield of the IOL over the posterior capsule. First we will go ahead and enlarge this rhexis, which is apparently small. A small rhexis has a problem that the periphery easily gets fibrosed, and this can be a common reason to have capsular phimosis later on, as these patients who are younger in age are also at risk of having this capsular phimosis, which can be really detrimental later on when the anterior capsule shrinks down too much and causes covering or cocooning of the IOL. Once the peripheral anterior capsule has been opened up to the desired size, we can go ahead and remove the remaining cortex. So this is one of the strategies to manage intumescent cataract, gauging the amount of intumescence they have. Surgery has been finished, and as we can see, the anterior chamber is being inflated and the incision is being sealed by hydrating it. This is the day 1 post-op picture, which provides us a good outcome. Thank you.